a compendium of ECG's 5-part series on the firm's insights on the challenges and future of healthcare in the U.S. We're glad you joined us today for this webcast sponsored by Becker's. I'm Darren Libby, a principal at ECG, and I'm pleased to be the moderator for today's session. Our featured speaker today is Andy Baccarat, a principal and senior strategist with ECG. Andy is a 35-year veteran in the industry and a senior advisor to organizations including regional health systems, community hospitals, children's hospitals, and academic healthcare organizations.
Thanks, Darren. It's great to be here today.
Excellent, Andy. ECG's healthcare experts have served as trusted advisors to some of the nation's leading healthcare organizations for nearly 50 years. We offer a broad range of strategic, financial, operational, and technology-related consulting services to healthcare providers and payers. Our clients include hospitals, academic medical centers, children's hospitals, regional health systems, medical groups, and payers. And ECG is a frequent partner and contributor to Becker's, and we are most appreciative of their invitation to share our insights and perspectives with this audience today. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be about 50 minutes in length, and as this is a pre-recorded session, we invite listeners to contact us directly with any questions following the session. Our contact information will be included at the end of the slides. Today's discussion is based on ECG's 5-part We Believe Strategic Perspective series on the changing dynamics of U.S. healthcare. Initially, we published last fall as individual white papers and webinars, and have now updated this material into a single compendium available at ECG's website, www.ecgmc.com. This series is intended to address some of the fundamental challenges facing U.S. healthcare providers and to set the tone for a future we believe will bring accelerated change. And while there remain areas of uncertainty, such as the next reform legislation and its timing, we believe the future also holds great opportunity for healthcare organizations and strong leaders that are willing to invest in future initiatives, provided that they lead their organizations boldly forward. Andy, as you are the architect for this series and author of the first paper in the series, the U.S. healthcare provider economic model is in critical condition. Set this up for the audience and share your perspective on the challenges facing health systems and other providers and what they can do about it.
Thanks, Darren. We'll spend a bit more time on this first topic as it sets the table for subsequent white paper discussions. Let's start with the big picture. Arguably, the U.S. healthcare system is the most complex and challenging in the Western world. And over the past several decades, it has become increasingly so, beset by a host of challenging dynamics, regulations, conflicting incentives between providers, payers, and employers and consumers. And of course, a level of national health spending that is substantially higher than any modern nation. Now, layer into that equation the COVID-19 pandemic. We witnessed the industry nearly collapse under a crisis it wasn't prepared for, only to emerge with great resiliency, a testament to the commitment of those on the front lines of healthcare. Of course, we're still dealing with the pandemic nationally, and it's still a serious challenge in many markets, but leaders in the industry are looking forward. Many are weary, most learned a lot about their organizations, and nearly everyone believes the experience of the pandemic and how their organizations, their physicians, their workforce, and even our government responded will change how healthcare will be delivered and funded in the U.S. going forward. Well, here we are, almost 18% of GDP in national health expenditures as of 2019, projected to grow to nearly 20% by 2029. Yeah, we can argue whether this is too much to spend on healthcare as a nation. A fair question, though, is whether we get the value for the spend out of our healthcare system. Data from multiple sources suggest we don't fare as well on certain measures of health outcomes, or even quality of life if considering life expectancy. Indeed, the U.S. chronic disease burden is higher than most other countries, and we know this has serious impacts on our healthcare delivery system and our cost. And while there's debate on either side of the quality and outcomes comparisons with other countries, where there's much more clarity and agreement is that the underlying cost, things like labor, pharmaceuticals, medical equipment, and supplies in the US are just simply higher than is the case in other countries. How is it, though, with all this money flowing through the US healthcare system, that we have so many hospitals in financial distress? ECG created a financial and operational health index that stratifies US short-term acute care hospitals based on a 4-year trend of operational and financial metrics. Our findings suggest that 35% of hospitals are marginal or at risk, and another 27% are technically failing or at high risk of failure, with the latter characterized by both negative operating and EBITDA margins on a year-over-year basis, at least for the last 4 years. Now, the top 6%, the peak performers, are characterized by strong double-digit operating and EBITDA margins, strong cash generation, and the ability to grow revenues much faster than expenses. Looking forward, it may get worse for some hospitals. As Medicare enrollment grows by 25% between 2019 and 2029, and as Medicare Advantage ranks swell, the payer mix for many hospitals will become a greater challenge. Add to this things like pricing transparency, an aggressive push to move many procedural cases out of the hospital, significant investments by private equity-backed ventures bringing all sorts of technological innovation and disruption to the traditional healthcare milieu, and we have a situation where many providers are not well prepared for the future. On top of that is the realization that the provider sector already is under a microscope. Of the growth in per capita spending since 2010, hospital care has accounted for 38% of that total spending increase, and physicians and other professionals another 33%. Let's face it, there isn't a lot of sympathy out there for what is deemed by many to be a wholly inefficient model of healthcare delivery. And then there's COVID-19, sparked, of course, an unprecedented financial crisis for most healthcare providers. Many organizations have seen a recovery of volumes lost during the pandemic, though by many estimates, the hospital sector financial recovery will lag all the way through the end of this year. Despite federal relief from the CARES Act, many providers have seen operating margins go deep in the red, and most are now experiencing significant workforce issues, adding to their financial challenges. The confluence of macro-environmental industry trends and the pandemic have created a situation that none of us have ever seen before, or frankly, ever desire to see again. And if the Hospital Insurance Trust Fund actually were to become depleted by 2026, as the Congressional Budget Office estimates, the situation gets even worse, a situation that can only be met by payment reductions from CMS, significant tax increases to consumers and corporations, changing Medicare and Medicaid enrollment criteria, and potentially even forced utilization reductions, and we're already shifting care to lower cost settings. The draconian measure might actually mean creating greater barriers to access through pre-authorization or even rationing care. There's no question we must grapple with all of these considerations in the years ahead. Some might suggest that healthcare is too big to fail, and that may be true, but it isn't too big to undergo transformative change. In the pre-pandemic world of healthcare, the industry had widely accepted the triple or quadruple aim, this concept of value, as a foundation of change needed to save the US healthcare industry. CMS and private payers alike have advocated pay for performance and value-based care models since the early 2000s. Unfortunately, the results have not been all that impressive. A number of studies indicate that these programs have neither demonstrably improved outcomes nor lowered the cost of care. Today, only approximately 14 or 15% of all payments in the US have some element of downside risk. Now, the objectives of the AAA make perfect sense. And Ian Morrison's second curve concept of value-based care transformation is deceptively simple. We have seen some health systems invest fortunes to scale and organize their delivery networks and build the infrastructure to control the premium dollar and manage populations. Others have waded in more cautiously. And we've seen some successes, and of course, we've seen some spectacular failures. I like futurist Paul Safo's point of view, which I think is relevant to this situation. Never mistake a clear view for a short distance. Indeed, the work of transformation can take time. Now, the transition to a fully value-based healthcare system has been complicated by the very structure of the US healthcare system and its complex, fragmented nature. all parties to any healthcare consumption in the US have contributed to our model's inefficiency. As you can see from this slide, the complexity, some might say insanity, is hard to fathom. You couldn't possibly intentionally design a nation's healthcare system to be this complex. I mean, you can't make this stuff up. Now, President Biden's administration hasn't pushed forward aggressively with its healthcare agenda to date. Even so, we do not expect the current healthcare model in the US to shift dramatically in the near term. In fact, in our view, our current model of government-funded healthcare and private insurance programs is so ingrained in our culture, and the lobbying efforts from the AHA, AMA, big pharma, and big payers are so powerful that a sweeping change via some revolutionary reform will be fraught with complexity and may require generations to implement. And even then, it's anyone's guess whether a reformed healthcare system will actually accomplish its objectives.
Andy, in the white paper, you make the point that the path forward, won't be without obstacles and setbacks. And the future will be characterized by, continued challenges for healthcare organizations, such as revenue and cost pressures mounting, eroding margins, the economy and the demographic shifts that will impact healthcare utilization and ultimately a payer mix as we have an aging population into Medicare. The industry disruption will continue. We have pressures on the economy that may yield more in terms of Medicaid and underinsured. And the margins and cash flow the outcome of this will be affected. Capital will become scarce for many. Sort of these unrelenting pressures. Well, where do healthcare leaders go from here?
That's right, Darren. And actually, why don't we just pop back to the prior slide? While the future may well be subject to many points of uncertainty, one thing is certain. Left unchecked, healthcare provider economics will remain in critical condition and perhaps even worsen. The key question then becomes, how can healthcare organizations optimize their business model to achieve a sustainable advantage and position them favorably for the future? In the paper, we lay out 4 key imperatives that every provider must excel at, and those that don't risk being marginalized. These are really table stakes for all providers. First, here's our perspective. Health organizations have to optimize their operations and cost structure. Our audience probably is focused on that throughout the pandemic, so that's probably not new news. Second, provider organizations need to optimize their revenue structure, both in terms of rates and contracts with payers, but also charge capture and revenue cycle. Third, providers need to redesign their delivery network for high performance, particularly in the ambulatory space, physician enterprise, and in optimizing the hospital clinical portfolio. And fourth, providers need to own the consumer relationship, especially as the digital frontier of healthcare delivery is upon us. We like to say it's not enough for our patients to say they would recommend us. We want them to say they wouldn't think of going anywhere else. We'll hear more about these imperatives as we work through the themes of the other white papers, but we advance these knowing that most every health system is addressing these in some fashion. Our point is that if your organization cannot do these things well, in fact, embed them into the DNA of the organization, then you'll find yourself in a constant cycle of ups and downs, and perhaps failure.
Andy, thanks for the introduction of the Strategic Perspective series. Why don't we shift to the second paper in our compendium, that is health systems must integrate and rationalize. If you'll share with us the key messages from this paper at this time.
Certainly. Our perspective in this paper, which builds nicely from the imperatives outlined in the prior discussion, is that redundancy, duplication, and waste are pervasive in today's healthcare delivery system, driving up both operating and capital cost. Some estimates are as high as $750 to $1 trillion in annual waste nationally, attributable to systemic inefficiency, an exceptionally high regulatory burden, fragmentation across the provider spectrum, an asset-heavy and in many cases functionally obsolete bricks and mortar delivery model, continued use of decades-old processes for managing patient access and processing claims. Of course, there's always the actual waste of supplies and the absence of a fully integrated information technology systems that make it very difficult for us to make data-driven decisions. Now, we believe that opportunities exist in both administrative and clinical functions of all provider organizations regardless of size, scope of services, and financial success. The vulnerabilities of the U.S. healthcare economic model and the intensifying pressure to demonstrate better performance in conjunction with increasing scale have led some organizations to proactively address these opportunities. And the financial repercussions of the COVID-19 pandemic will compel more systems to do the same. When we talk about integration and rationalization, so what is it that we're really trying to do? First, let's define the terms. Integrate means to form, coordinate, or blend into a functioning or unified whole. Basically, it means better together. Rationalize means to make our business more effective and or efficient, usually by combining or stopping particular activities in conjunction with the appropriate deployment of workforce and technology. So our goal is really simple. It's to move toward a desirable future state that is more effective and efficient, has lower costs, and enables better engagement and experience for both patients and providers. Now, we focus on 4 key imperatives in this paper for integration and rationalization. First, capitalize on technology for business process innovation in areas like revenue cycle, access and scheduling, and to tap into the wealth of data we capture in our EHRs to inform data-driven decision-making. Second, design a platform for coordinating and delivering care across the continuum, which requires strength of physician alignment, an integrated EHR, and thoughtful consideration around which aspects of the clinical portfolio we will control and be excellent at, and which elements of it we may contract for. Third, eliminate unwanted clinical variation through adoption of clinical protocols and standardization. And therein probably lies the greatest opportunity for improving our cost structure and quality nationally. And fourth, implement a capital asset plan that supports integration and rationalization. Now, in our experience, we see healthcare organizations fall into one of 3 stages of integration and rationalization. Most are somewhere in the middle stage, having accomplished some degree of basic business integration, commonly in back office functions in stage 1, moving into more complex aspects of integrating their business and clinical operations in stage 2. I'll touch on these 3 stages of integration and rationalization briefly. First, in stage 1, this is the developing stage. These are systems that are earlier in their integration journey and focus, for the most part, on the types of business operations that make little sense not to centralize. Their emphasis tends to be in areas like revenue cycle, physician alignment or employment, perhaps moving to standardized employment or PSA agreements, compensation models, and even some facility consolidation or rationalization. Stage 2 is the maturing stage. These are more advanced systems. They have the foundational stuff nailed. They're tackling bigger challenges now, things like patient access and engagement, creating an integrated technology ecosystem across their provider network, rationalizing facilities, and often with the deployment of service lines that place physicians in leadership roles who champion the creation of clinical standards and protocols. In the value world, these organizations are performing well under value-based care contracts and typically have fully developed clinically integrated networks that put real emphasis on rewards behind their actions. Stage 3 is the advanced stage. And honestly, we don't really see many organizations as fully advanced in their integration or rationalization journey, though many are making progress. The large super-regional national systems, they've made great strides here. Though many regional systems and even academic systems with community networks haven't made great progress at this level. The advanced organizations operate culturally, if not from a P&L perspective, as a single enterprise, not beholden to business unit silos that so often are the barrier to real integration and rationalization. They might take significant financial risk on payments, even full capitation, and operate effectively as population health organizations. They think long-term, not in terms of annual budget cycles. Now, the benefits of integration and rationalization are real. Whether it's in creating a better patient experience, truly engaged physicians in driving solutions, better quality and clinical outcomes, or in achieving a consistent and sustainable financial performance, those that are well down this transformation journey can't imagine running their health system any differently, except for continuously trying to make it even better.
Andy, thank you. Many great insights related to the imperative to integrate and rationalize. The third topic in our Strategic Perspective series is health system scale is irrelevant without performance. The first two perspectives in the series stem from our belief that we've entered a new era for healthcare, one where we must accept the journey towards value and it must accelerate, and that health systems require a strong foundation in the business fundamentals of running their organizations, simply because the underlying economic model isn't changing anytime soon, and that integration and rationalization have to be part of that solution. Now let's turn to scale, something many healthcare organizations have been very focused upon. Share your perspective on this topic, Andy.
Darren, some context is important here. For decades, health systems have been aggregating into regional, super regional, and national health systems, predicated on a strategy of gaining economies of scale, standardizing and improving care, building balance sheet strength to lower cost of capital, that sort of thing. In the 10 years since the passage of the Affordable Care Act, we witnessed continued industry consolidation into systems and large numbers of physicians becoming employed by health systems or aggregating into super groups. And in many cases, similarly predicated on the belief that scale is important to improve quality, lower unit cost, and to fund the infrastructure needed to make payment risk and manage the health of populations. Now, we believe scale does matter, and it's needed to achieve a level of market indispensability, but size or scale doesn't guarantee relevance. Our perspective is that only those health systems that build scale while also advancing performance across quality, safety, service, as well as operational and financial measures are the ones that are driving real value. And to go further, if they're lowering costs to consumers, their value benefit is even greater. Now, however, in many instances, what we see is that systems build strong balance sheets by elevating the performance of their individual hospitals through the types of integration and rationalization efforts we described in the previous section. Though, many do not reinvest proportionately in those communities in deference to needing to support underperforming hospitals elsewhere in the system. And few have returned the benefits of scale to employers or consumers in terms of lower cost, partly because there's no guarantee pricing cuts to payers find their way back to purchasers as lower premiums. Now, some health systems do build their balance sheet for investments in non-core ventures. Some are wanting to own the entire continuum. Some are even starting their own health plan. We could probably all point to some wins and some spectacular failures. An often heard complaint among hospital executives that are part of large systems is that the only part of the system that is growing is corporate operations and overhead. Clearly, bigger doesn't always result in better. Now, to illustrate our point in a white paper, we looked at publicly available data and focused on measures of market size, system size, quality, and financial performance from the top 50 metropolitan statistical areas across the country. These MSAs account for approximately half of the nation's population. We found that the largest 3 health systems in each MSA substantially exceed the median financial performance of all other systems in their markets, and they perform slightly better on quality performance, using CMS star ratings as a proxy for that measure. Now, when we look at measures of market concentration, the degree to which the market is consolidated based on the Herfindahl-Hirschman Index, the median operating margin of the top 3 systems in highly concentrated MSAs is over 7%, compared to the median operating margins of basically 0 across all market participants in MSAs of moderate and low concentration. Furthermore, the top 3 highest performing health systems in the best performing MSAs typically have a combined market share of greater than 80%. This is the case in 17 of the 20 most highly concentrated MSAs. Now, based on these results, we can infer that performance is optimized by large systems in highly concentrated markets. Markets outside of the top 50 MSAs tend to have fewer health systems, so they tend to be more concentrated. So they're typically in the moderate or the high level of market concentration based on the HHI metric. And while our study was on the top 50 MSAs, it did let us understand how systems in markets that have low concentration perform. And the answer to that is not so well, generally. As we can see on this slide, the median operating margin and median CMS star rating for all systems within MSA do not correlate with market concentration. If high concentration and good performance went hand in hand, then we'd see all the dark dots, the black dots in the top right, and all the red dots in the bottom left. But the MSAs are all over the place. So there's three key insights we can draw from this slide in the prior two slides. First, regional market dynamics play a large role in financial and quality performance for all systems operating in a market. Number two, large disparities in performance exist between the top three systems and the rest of the systems within highly concentrated markets. And three, as concentration increases over time, that's market concentration, something we believe will continue to happen, by the way, the delineation between market leaders and laggards is accentuated. But these findings aren't really surprising. In fact, they're common in most industries, especially the more mature ones. Now, with few exceptions, firms in all industries benefit from scale, and so do their customers. This concept of the rule of three has emerged as a business principle that we believe has applicability to healthcare, even on a regional basis. In short, we believe that markets that have not already consolidated will do so, such that three health systems will account for a large majority of the market. We also believe that the three largest health systems will almost always perform better than smaller general systems. And finally, we believe that specialists or niche providers, single specialty hospitals as an example, may maintain high performance, as long as they maintain high performance, will continue to be hold a key place of differentiation in their marketplace, provided they don't stray too far from their core competency. Furthermore, we should expect the growth of national and multi-regional health systems to not only continue, but to actually intensify. And finally, the additional financial pressure placed on independent hospitals and small regional providers by COVID-19 is driving many of them to seek the enhanced security of a larger system. What we've learned from the best performing systems are these 5 points. First, don't look for scale to create performance. Achieve performance first and then scale by integrating new organizations and new growth into your high-performing business. Second, engage physician leadership to drive system-wide reduction in care variation. The system's job is to enable physicians to design, develop, and implement solutions to reduce variation and spread innovation. Physicians need to be empowered with timely cost, quality, and outcomes data that can support consensus building and guide decision-making. Third, optimize business integration through centralized and shared services. Standard non-strategic functions such as revenue cycle, patient contact centers, supply chain, finance, legal, HR, IT, etc. These should all be managed at the system level. Although economies of scale should not in itself be the most compelling reason for a hospital to join a system, we have to conclude there is real value in doing so. Fourth, establish an effective consolidation and rationalization strategy. This is one area where many health systems can do better, especially when it comes to making tough decisions regarding clinical portfolio rationalization or asset elimination. We have a hard time saying no in this industry. There's also an element to this around building expertise at the system level to spur growth and expansion, especially in alternative lines of business and revenue sources that will expand a system's breadth and drive innovation. And finally, systems need to really align their culture, their strategy, and their brand. What we see is that winning organizations have a unifying culture across the system, not unique cultures at each business unit. When culture, strategy, and brand are aligned, the experiences of patients, consumers, employees, physicians, donors, volunteers, whoever, they're connected, they're consistent. It brings great value to the organization.
Andy, those are some excellent insights on system performance. I'm quite frankly surprised we've gotten this far into the discussion and haven't mentioned digital health. That's the topic in the fourth of our Strategic Perspective series. And I happen to co-author our paper, Digital Health Will Reshape Care and Payment Models. So let's discuss this one together.
Absolutely, Darren. So first, let's define what we mean by digital health. Like disruption and transformation, digital health is a term that gets used a lot, but means different things to different people. At ECG, we define digital health as a use of technology to advance the delivery of better healthcare and enhance the well-being of individuals through heightened patient engagement and more precise, personalized care. Many organizations define digital health quite narrowly, focusing on patient engagement. We see it inclusive of that, but yet broader. Patients connected health digitally, enabling better care, and even enhancing operations. It really is a means that can thread through every aspect of our healthcare delivery model. It requires both a strong analytics capability and a contemporary technological infrastructure. What's clear, though, is that many organizations are beginning to realize that the future of healthcare is digital, so they're adopting a digital-first strategy.
Andy, let's stick with that theme, digital first, which is often highly correlated with the concept of consumerism in healthcare. The differentiator of a digital first strategy, we believe, is that technology allows the organization to scale personalized, consumer-centric care. And we know that consumers, i.e. patients, have choices. So the increasing level of transparency in both price and outcomes data are only amplifying consumer expectations regarding the demand for timely, convenient access to healthcare systems and services. And we've become an on-demand society, and healthcare providers are not immune to this rise in consumerism and a on-demand mentality. This necessitates that healthcare systems establish a multifaceted consumer engagement approach that invests in consumer relationship management and tailors interactions with unique individuals. We've decades behind other, we're quite frankly decades behind other industries in adopting this digital strategy, is using technology and data as a means to engage and conduct our business with customers. And that extends beyond patients to include physicians, other providers in the region and along the continuum, and payers. In the rapid adoption and expansion of virtual visits during COVID has only been a catalyst and amplified the necessity to implement more comprehensive digital health plans that integrate technologies and share data across the continuum. There's no argument among industry leaders that integrated, coordinated care is better. However, health systems have struggled to make this a reality, given the fragmentation of providers in the US healthcare system and those that exist across most regions in the country. Now there's a convergence of an array of technologies that is resulting in accelerated advancements in the prevention, detection, treatment, and recovery of patients. And this requires going beyond the transactional encounter and beginning to integrate data and applications across care settings, including ambulatory, acute, post-acute, to exchange real-time data among providers. The extent is to provide the right data, the right care, at the right time, in the right setting. One of the domains that we are seeing increasing focus on is the concept of the digital front door. Much of the front door strategy of a hospital is the outpatient clinic, used as a primary access point for face-to-face encounters. But the digital front door means that we're transitioning to digital interactions with consumers and patients.
Yes, that's right. In our view, a key design principle for the digital front door is that it should allow for using the consumer's preferred channel of communication. This will provide the ability to attract, engage, and build a trusted relationship with consumers and patients and offer stakeholders convenience, ease of use, and increased adoption. Now, I am not one of ECG's digital technology experts, but I do know that health systems will need to establish robust backend platforms with foundational capabilities, which include things like data storage platforms, the analytical tools, interoperability capabilities, patient interface tools, and CRM tools, customer relationship management tools. So building on these foundational capabilities, the back-end applications will serve as the source of all clinical and non-clinical data across the entire care continuum, whether it's outpatient, inpatient, and post-acute settings. So to facilitate the development of this infrastructure, clinical tools such as EHRs, we believe will evolve from documentation tools to smart solutions that allow clinicians more direct interaction and help facilitate the practice of evidence-based medicine. Additionally, organizations will increasingly turn to digital health tools, including artificial intelligence, to enhance both the front and the back-end workflows, to deploy automation, and to drive operational efficiency.
Andy, I think we can confidently say that digital health has a place in healthcare and that it will be a key factor in shaping the future of our industry. With that, quite likely future payment models will also be impacted by these changes. And based on ECG's recent survey of health system clients, greater than 60% of the respondents indicated increased investments in digital health tools in developing approaches to understanding the importance of data in key decision making. There's greater appreciation for the parity of virtual visits versus in-person visits. And patients, providers, and insurance companies alike see value in the use of digital health solutions as a way to interact with patients as well as drive more personalized, precise solutions and care to patients from a care delivery standpoint. Our white paper outlines a host of insights related to digital health that go beyond our discussion today. So let's shift, in the interest of time, to our final topic in ECG's Perspective series, and that is future generations will value wellness over healthcare. Andy, please share your insights on this final topic with our audience.
Absolutely, Darren. Well, the preceding digital health discussion is actually a pretty great segue to this topic. First, let's understand the dramatic shifts that are occurring globally and certainly in the US in terms of demographics. In just 4 years, the baby boomer population will all be age 65 or greater. They and the oldest of Generation X will be transitioning out of the workforce. By 2030, that's less than 10 years from now, the millennials and Generation Z will comprise the majority of the workforce. And oh, by the way, the electorate. Another significant change in demographics is that by 2034, the primary drivers of population growth in the US will be foreign-born individuals. And for the first time, we will see the number of older adults, those folks age 65 and over, outnumber children for the first time in US history. Today, the average age of a nurse is 54 years old, and over 25% of active nurses are already at retirement age. We're in for some significant challenges in the decade ahead. Now, all of us will no doubt have to address the workforce of the future, but our emphasis today is how the younger generations view healthcare and what they will expect of it. So here's some perspectives. First, healthcare health systems need to take note of what's to come. You know, as Yogi Berra once said, the future ain't what it used to be. Yeah, I know I just dated myself. And for those that don't know, Yogi was an iconic baseball coach from the 1940s to the early 1960s, Hall of Famer and an unknowingly a humorist. So, but here's the perspective. The views of millennials and Gen Z, they couldn't be more different than how we organize, deliver, and fund healthcare today. We should expect changes, systemic change in the years ahead. Now, let's appreciate that many among the millennial and Gen Z age groups have the same health status issues as the generations before them. The number of people with chronic and polychronic conditions is probably going to double in the next decade, and 1/2 of the world's population is going to be considered obese in about 10 years. That said, the reality is that these younger generations view today's healthcare model, hospitals and subspecialty expertise, as a safety net. It's more of a right to them than a privilege. And many believe that healthcare should be more holistic in terms of, in terms of focusing on mind, body, and spirit oriented than it is today. The reality is, for these generations, wellness matters. And it should be part of the overall healthcare economic equation. Now, earlier, we discussed that health systems need to own the consumer relationship. And that couldn't be more true than how we engage with today's younger generations. Excuse me, I've lost my voice.
I know, Andy, as we're talking through the wellness topic, it sounds like you need a dose of maybe a glass of water or others. If you'd like, I can carry on through slide 36 and provide any perspective.
That'd be great, Darren. Thanks.
Yeah, Andy, I think that as we go to, and continue on this topic, I think that it's, important to know that the sky isn't falling here. And the truth is that many of the millennial and the Gen Z populations are vested in today's healthcare model as the generations before them. But we need to anticipate their needs, if not demands, and to bring healthcare forward in terms of a more contemporary model. And one of the places where there's a good amount of value on wellness is with incentives for them in terms of maintaining good health, such as premium reductions, as well as other incentives for providers to help their patients to manage their conditions and maintain a healthier lifestyle. And these solutions, we see are helping our clients navigate with respect to the evolving sort of generational demands and differences that we see across our population of patients. And those demands on our health systems really include, the implementation of we talked about consumer-facing digital applications and a digital strategy that we outlined in the previous section, as well as then creating direct-to-consumer models for basic healthcare and wellness services. And this may include subscription services and membership models, but also in this era of healthcare, the younger generations do place a premium on these services and prefer their employers to provide, if not purchase them directly, is a kind of safety net solution for catastrophic needs. And finally, healthcare systems need to expand their horizons and move beyond just the chronic and acute conditions. Today's hospitals is the engine of healthcare provider economics, will be tomorrow's cost centers. And we need to expand our view of healthcare beyond bricks and mortar, create strategic partnerships with some of these community organizations that we currently consider to be disruptors in the industry, and begin to diversify our revenue streams that will embrace both health status and wellness, as well as then the components to deliver care when patients and consumers are in need of interventions or treatment. Andy, I don't know if there's any parting comments that you'd like to provide as I picked up slide 36 related to the topic.
Thanks for covering my senior moment there, Darren. I appreciate that. I think you hit all the high points, and I think just in closing, really significant issues that are out there facing our industry, and I encourage everyone to take a look at these white papers. I know you have some closing comments relative to the webcast, but we'd like to thank our audience for their time today.
Thanks, Andy. And I know that we have covered a tremendous amount of territory during today's webcast, covering the 5 ECG strategic perspectives. And I think it's evident that the healthcare economic model for providers is in critical condition. And while some may get worse in terms of their performance, we do see a path forward. And I am optimistic that our industry will embrace the challenges, capitalize on opportunities, and forge ahead with strong leadership to create a better healthcare system for our country. And navigating this path forward does require vision, strong leadership, a healthy respect for uncertainty, but also a firm belief that if provider organizations are not proactively driving change in the U.S. healthcare system and in their communities, it will be done by others while they sit on the sidelines, and the result will be a marginalized organization by those that are advancing the delivery system in our country around healthcare. Andy, this concludes our formal webinar. And first, I want to thank Becker's for hosting this, and thanking each of you for joining the discussion. If you have any questions, don't hesitate to contact either Andy or myself with any of those questions or comments. We appreciate feedback and would love to continue this dialogue with you in the future. Thank you for your time.